Hi, I'm Beryl Benassarat. I'm going to be talking to you about how to evaluate the patient that presents with pelvic pain using ultrasound. I have no disclosures, no financial disclosures. The learning objectives are noted here, and we are going to learn how to use ultrasound effectively to evaluate patients with pelvic pain using a combination of imaging, physical exam, and pain-guided uh, imaging ultrasound. We're going to understand how to use ultrasound to evaluate these patients because we're going to learn about all the manifestations of endometriosis, which is a big reason why patients have pelvic pain. And we're also going to learn how to use 3D ultrasound as an essential tool in evaluating patients with pelvic pain. So the lecture outline is shown here, and you can see that it's divided into basically three portions: uterine causes of pelvic pain, which you can see here, and adnexal causes of pelvic pain, including ovarian and adnexal, and then non-GYN causes of pelvic pain. Now, pelvic pain, the reason that we're talking about it is a big public health problem. It affects more than 15% of women, and many of these patients never get a diagnosis, and they live with their pain really affecting the quality of their life. Patients with pelvic pain deserve more than just a series of standard pictures of just the uterus and the ovaries. You have to individualize the exam because these patients present with a problem, and we have to be problem solvers in approaching these patients. And that approach is essential for finding the cause of pelvic pain. So first of all, you want to get a history from the patient. You want to know if the pain is acute or chronic, whether it's diffuse or focal. You want to know when it's happening, whether it's cyclical, sharp or dull. You need to know whether the patient has surgery before, the menopausal status and hormonal status of the ovary, and of course, you need to know whether she's pregnant. During the scan, you want to ascertain how tender the patient is, whether she is able to speak to you or whether she is in a great deal of pain and can't talk. Where is their tenderness? Is it focal? Does it seem to be on the right side, on the left side, in the middle, in the cul-de-sac? Do the organs slide past each other? We'll talk more about that when we get to endometriosis. So you can push deliberately, gently, on each part of the pelvis with the probe, and perhaps with your other hand on the belly, and see where the pain is from and what is moving. So we talk to the patient during the exam and find all this out. So let's start out with the uterus. Adenomyosis, a degenerating fibroid, and prolapsing fibroids, of course, and abnormally placed IUDs. So let's start with adenomyosis. It's considered a type of endometriosis of the uterus in that it's characterized by invasion of the endometrial glands into the neighboring myometrium, causing a blurring of the junctional zone. The symptoms are dysmenorrhea, abnormal bleeding, uterine enlargement, and tenderness. The appearance of a uterus that has adenomyosis is very mottled and inhomogeneous. It's globular, it's enlarged, it's asymmetric with one side of the myometrium thicker than the other. The endometrium is often not easy to see because of the blurred junctional zone, and there may be some small subendometrial cysts that represent the small glands. So let's look at some examples. Here you can see a large globular uterus. The endometrium is way over to one side. It's ill-defined, hard to figure out where to put the calipers. This is another case where you can see the thickening on one side versus the other of the endometrium. The calipers are attempting to measure the endometrium. Here, their calipers are trying to measure something, But in fact, there's nothing to measure because this is not a fibroid. It is very diffuse, heterogeneous appearance of the myometrium. And here again, perhaps the endometrium is here, I'm not even sure. Now, sometimes you can see these cysts, and they can be subendometrial, they can actually be in the myometrium, and you can see how ill-defined the endometrium is, or the junction is. The color sometimes helps to distinguish adenomyosis from fibroids. The fibroids tend to have more of a circular color pattern, but it is not necessarily that helpful in every single case. 3D, though, can be helpful in that when you do your coronal view of the uterus, your reconstructed coronal view of the uterus, patients with adenomyosis have these striations that sort of make or demonstrate that the junctional zone is ill-defined. And here is a more severe one where you can see these cystic areas quite nicely that are very typical of adenomyosis. Here's another case of adenomyosis, fuzzy junctional zone here all around. But if you look at it with inverse mode, and we'll talk more about inverse mode later, but where the echogenic areas become lucent and vice versa, and you just inverse the image, you can actually see much better how these lucencies actually stand out. Now, here is a lesion inside the cavity. We don't know what it is. Looking at this, we don't know if it's a polyp or a fibroid. It turns out we put a little bit of saline in, and we outline this very strange rectangular-shaped lesion, which turned out to be an adenomyoma. So adenomyomas are often different shape from the fibroids, is that they're more malleable as well. Now, fibroids are obviously very common, and most of the time they don't necessarily cause pain. They cause bleeding more often than they do pain. But sometimes the positioning of the fibroid can cause pain if it's pushing on something or pushing on a ureter, or if it's prolapsing, or if it's degenerating. And degenerating fibroids may be quite symptomatic. The size of the fibroid may also cause discomfort due to pressure, such as hydronephrosis. So degenerating fibroids can look quite unusual. Here are 3 different ones. This one down here is more typical. It's got a central cystic portion with a thick rind around it. You can see the shadowing, which is quite typical of fibroids. This one also has a thick rind around it, a little bit less typical, but again, if you can identify separate ovaries, this would certainly qualify as a degenerating fibroid. This one, on the other hand, I think is more difficult to diagnose because the edges are not thick. And so you might think this is adnexal rather than a fibroid. But in fact, this was proven to be a degenerating fibroid. Now, here's one that looks very, very much like an endometrioma. In fact, we thought it was an endometrioma, and it went to the operating room, and it turned out to be a degenerating fibroid. So they can really mimic other pathologies, so you have to be aware of that. Of course, here was an ovary, which could have tipped us off to the fact that this was probably part of the uterus, but difficult to tell. Now, abnormally located IUDs are often a cause of pain in the pelvis. Now that we have IUDs more often, they can cause pain and bleeding. And this one here, and you can see these best with 3D, where we reconstruct the coronal view, and you can see that the arms of the IUD are embedded in the lower uterine segment, and the shaft of the IUD is actually in the cervix. Here's another one, where again the shaft of the IUD is in the cervix. Here, one arm is completely embedded, but you can see that nothing is really up in the fundus of the uterus where the IUD should be. So here, where is the IUD? Well, the IUD certainly looks like it's in the uterus. Certainly the shaft is in the uterus. The question is, where are the arms? Well, the shaft is a little low in the uterus. It's not quite at the very top. And because the uterus is a triangle, I would worry that the arms of the IUD are embedded. And in fact, they were, but we could only see it with 3D. So here you can see the arms are embedded in the body of the uterus, well below where it should be. So some IUDs are easier to see than others. The Mirena on your left is more difficult to see because it had than the Paragard on your right. The Mirena has a lucent tail, if you will, or shaft, and there's only a couple of echogenic spots here where you can identify the arms. So it's a challenge to locate Mirena IUDs, particularly when they're not in the right place. Now these are IUDs from other countries, and you can see how they look quite different, and with 3D ultrasound you can delineate how they look and where they are quite easily. And this is the tubal coils, the eshores. You can see these are positioned right at the tubal edge here. This one is a little down further down the tube, and you can see them quite clearly on these 3D ultrasounds. So we did a study looking at the patients who came in who had IUDs. And we looked at whether or not they were embedded and what the indication for the scan was. And those that had an embedded IUD, you can see here, had a higher incidence of pain and bleeding and had a 70% incidence of coming in for the scan because of either pain or bleeding. Whereas those who had an IUD that was not embedded had a much lower incidence of pain and bleeding, and you can see that that was statistically significant. So how do we find these IUDs when they're difficult to see? Well, you can see that in this 3D volume, I've put my render box just underneath the IUD, and I've caught the shadow right here. I'm catching the shadow in both of my A and B planes, which means that my C plane will look like the IUD, but it won't be the IUD. It'll actually be the shadow. And then I can walk back looking at the shadow and then catch the actual IUD. Let me show you how that works. Here is an IUD clearly upside down. It's also larger than it should be, and that's because shadows are larger than the actual item. And so we can walk back into the Mirena IUD, which now you can see much better, and it's upside down. So when they're not in the right place, they can be very difficult to see, and the shadow can help us a lot in visualizing them. Now in this case, here was the IUD, but we couldn't tell where the arms were. We looked and looked, but the arms were really low because the IUD was upside down, looked like an anchor in this case. Now here is another IUD. That looks pretty good. So why are these IUDs not fitting? And that's because the uterus tends to be too small in many patients. And when the uterus is too small, the IUDs can't open up because the IUDs are all the same size, at least until a few years ago. So we actually did a study looking or trying to determine what is the size of the normal uterine cavity. That really hadn't been done. And we had the opportunity on 221 consecutive patients to measure the normal uterus across the fundus on the reconstructed 3D view. And the mean width of the normal uterine cavity was 29 millimeters. Turns out that it was 27 millimeters in the nulliparous patients, compared to 32 millimeters in those that had one or more pregnancies. Now, we also looked at other variables, and there was no appreciable relationship between the width of the uterine cavity and other variables such as prior C-section or patient age. So what's interesting is that the IUDs are all 32 millimeters. And clearly, as we measure the fundus of the uterus, some IUDs are just not going to fit. And secondary to this study, they came out with a skylar that is actually 28 millimeters and will fit better in the nulliparous patients. Now, it's important not to put an IUD into a septate uterus. Here's a septate uterus. The IUD has gone out, and no wonder this patient came in with pain. You can see that the puckering of the serosal surface of this uterus. Here's another septate uterus. This one is quite deeply septate, and of course the IUD is not going to get to the top. Clearly remained in the lower uterine segment in this case. Now let's go on to causes of pelvic pain that regard the ovary and the adnexa. We're going to be talking about hemorrhagic cysts, hemorrhagic corpora lutea. We're going to be talking about torsed ovaries and tubes, endometriosis, hydrosalpinges, adhesions or peritoneal inclusion cysts, and pelvic inflammatory disease. So let's start out with those that relate to the ovary, which are the top three here. And we can start by looking at these cysts that are really quite characteristic of the hemorrhagic cyst. You can see that all three of them, and these are three different patients, have a very reticular-like pattern of the material inside the cyst. You can also see that the surface of this material is very smooth, and it looks like it's retracting rather than growing inwards as a nodularity in a cancer would do. It is all very smooth, and here you can see it's really retracting from all sides. Now, if we turn on the color, very, very important to do, you can see the circumferential flow, the ring of fire, which is so important to diagnose a corpus luteum. This is a hemorrhagic corpus luteum. The bottom two images are from the same patient, and you can see that there is no color flow inside the clot, which is inside the cyst. This is a torsed ovary, and you can see how enlarged and edematous this ovary is. It really looks like a rather homogeneous type of enlargement. It doesn't look like there's a particular mass somewhere. And there are also small follicles in the periphery here. Now, this patient obviously came in with a lot of pain. You can see the pedicle seems to be rather swollen as well. Now, here's the key, is if you turn on the color, you will find the whirlpool sign, which is a very reliable sign of torsion of this ovary. Now, you can have color in the ovary or not. That doesn't seem to have really an impact on whether or not this is torsed, so that you can have a torsed ovary that has color flow. So going on to endometriosis, that's a big subject because it is so common, and it can be present in any part of the female pelvis, and it can be a cause of pelvic pain in many, many patients. So the typical presentation of endometriosis as we see it by ultrasound is the endometrioma, which you can see here measured on the calipers. It's a cyst that has relatively smooth wall, but not always. But it has that characteristic low-level ground glass echoes that is unclotted blood, if you will, of the inside of the endometrioma. Now, endometriosis in general tends to be quite sticky, and so there are a lot of adhesions associated with it. Oftentimes the ovary is adherent to the back of the uterus, to the bowel, and there are a lot of episodes of hydrosalpinges, as you can see here, associated with endometriosis because of the kinking and scarring of the tubes due to the endometriosis. Here's another example, different patient, but really the same scenario. Here you have a typical endometrioma. You can see with the color stays on the circumference of the cyst, not on the inside. And there is a hydrosalpinx as well in this case. Now, these two cysts look like endometriomas. But let's see if we can distinguish them. One of them is an endometrioma and one is not. So this one, you can see as we turn on the color is obviously on the outside of the cyst, but there is no streaming of the material inside the cyst. Now, in this case, there is streaming inside the cyst. You can see that there's movement of the low-level echoes. And that usually does not happen in endometriomas. Now, I say usually, it's not 100%, but it's a very helpful sign because streaming is unusual in endometriomas, and it is very common in mucinous cystadenomas or other types of lesions. Now, this lesion has a very coarse type of echoes throughout it. It makes you think of an endometrioma, but then you say, well, probably not because it's too coarse. And in fact, you'd be right. This is not an endometrioma. This turned out to be a struma ovarii. How about this one? This one we thought was a dermoid. This one looks solid. It has an echogenic area in it with shadowing behind it, very much like you would expect a dermoid. This went to the operating room, and it turned out to be an endometrioma with a calcified clot. So different lesions can mimic each other, and you have to understand that in trying to make these specific diagnoses. Now, there are many unusual sites for endometriosis. In fact, probably most of endometriosis occurs all over the pelvis and really does not manifest itself necessarily with an endometrioma. Here is a little implant of deep infiltrating endometriosis. You can see here in the cul-de-sac. This one has implanted in the wall of the bladder. You can see it's indenting the bladder here. It's insinuating itself between the bladder and the front of the uterus. So let's look at bladder endometriosis. These are two different cases. The one on the left is a rather smooth fusiform lesion on the floor of the bladder, which is very typical of endometriosis. If you turn on the color on these lesions, there is some color but not much, and that's usually what we see. Now, this one looks a little bit more aggressive in that it's a little bit more seems to extend a little bit further in the wall here and even into the serosa of the uterus. Hard to tell because everything is fused together here and stuck together. These patients obviously have pain in urinating, and these are two cases of fairly extensive bladder wall endometriosis. Now, here's a 24-year-old, and these can be quite young, these patients with really extensive stage 4 endometriosis. The tube here is very dilated. This is a tubular solid mass. Really nothing specific about it. You really can't tell what it is just looking at it. But if you look around at the rest of the pelvis, you'll see here in the uterosacral ligament region that there is a solid lesion here and maybe some other areas here and there that are evidence of deep infiltrating endometriosis, and so that really fits in with a diagnosis of extensive tubal and pelvic endometriosis. Now, this patient came in with right lower quadrant pain, and this was the region of the appendix, and this was actually endometriosis implant on the appendix. Obviously, we thought it was acute appendicitis, which is very similar to this other case on the right, which is actually a case of acute appendicitis. But you can see that the endometriosis can involve the appendix as well. Now, if you look at this case here, when I run the clip, you'll see that here we are in the posterior fornix, and this is the back of the cervix right here. This is the rectosigmoid. This is the lumen or serosa, mucosa right here, rather. And the serosa, which is normally this rather dark area, is very abnormal here. So I'm going to run the clip now, and you can see that as we push in the posterior fornix, nothing slides here. Normally, the back of the uterus should slide very nicely along the front of the rectosigmoid, but this nodular solid area of deep infiltrating endometriosis has basically stuck the front of the rectosigmoid to the back of the cervix. Now, this is a normal case where you can see the cervix right here, and as we push the cervix, it glides normally across the bowel behind it. So this is a positive sliding sign. The prior example was a negative or abnormal sliding sign where the things do not slide. The comet sign of endometriosis is basically shown here, where you have areas of implant of deep infiltrating endometriosis in the muscularis of the bowel, right here and right there, along here, and it's rather spiculated, and it has a little tail like this, and it almost sort of looks like a comet, I guess. But this is a typical implant in the bowel wall, mostly in the muscularis, but it can extend, when it has these little spicules, it can extend deeper than the muscularis. Now here's another lesion. You can see this one is smoother, so it probably just is in the muscularis and hasn't extended beyond that. But you can also see that there's not a whole lot of color in these lesions. Now here's another two lesions. This is one showing the bowel wall in cross-section. So here you have the mucosa right here, and this is the muscularis on the outside, and you can see that it is completely adherent to, in the cul-de-sac, to the back of the cervix. This one, on the other hand, is a little implant which is also sort of freezing the pelvis, where everything is going to be stuck together. So endometriosis is very sticky, particularly when it occurs like this in the cul-de-sac. Here is another example of the deep infiltrating endometriosis, where you can see that there's sort of a fan-like appearance right there as you come to the end of the clip. And this is probably an area where it has infiltrated a little more than just the muscularis. And here is another example. You can see the spiculated look of this rather extensive sort of maze of endometriosis involving multiple loops of bowel in the cul-de-sac. So deep infiltrating endometriosis in the cul-de-sac is quite characteristic. It occurs at the top of the rectovaginal septum, and you can see it really best from the posterior fornix using a rather near view setting, because here we're only just a couple of centimeters deep. And this is an example of the mucosa here. This is the normal muscularis back here, and this is the nodular muscularis, which is involved with deep infiltrating endometriosis, and this is another lesion, and the whole thing is just plastered up against the back of the fornix and rectovaginal septum, as well as the cervix right here. This is a transverse view showing this lesion right here is the same as this lesion right there in cross-section, and then here you see one of the nodularities, and you can see how everything is sort of cascaded and stuck together, whereas the cervix really ends here. So all of this is all implants of endometriosis. This one, different patient, shows more of a spiculated look, which is thought to be some further invasion into the region of the mucosa. And you can do a 3D volume, and when you have the volume, you can then view it in all sorts of different ways, display it as a tomographic set of cuts, just like a CT or an MR would look like. And here you can see these nodules along the wall, and the coloring of the image can actually sometimes show more detail to the eye than the black and white. So ultrasound is really quite accurate in detecting deep infiltrating endometriosis. As early as 2004, there were studies coming out showing that the sensitivity and specificity for detecting this kind of disease was almost 80% and 95%. And the sensitivity was best for intestinal and bladder disease. Obviously, those are closest to the probe, and probably less accurate for some deeper disease, such as a uterosacral ligament. This was a study in 2011 looking at 10 prospective studies of more than 11,000 patients. And you can see that the sensitivity and specificity right here is quite high looking at these 10 prospective studies, and the accuracy is good. The likelihood ratio is very high, 30, and the negative likelihood ratio is also excellent. So again, 10 different pelvic sites were looked at in this particular study, 2013, 420 patients, and they were compared to laparoscopy. And you can see the sensitivity is not as high in this particular study, but you can see again that it is the highest when you look for rectosigmoid lesions, because it is right there at the posterior fornix. Now, very recently, Guerriero looked at 19 studies in a very large exercise looking at 2,669 patients, and found that the sensitivity of ultrasound for detecting deep endometriosis was 91% and the specificity 98%. And you can see a very, very good likelihood ratios, positive and negative. So there's really a lot of evidence that if you look carefully at the area right behind the posterior fornix, right at the outer edge of the posterior lip of the cervix, where the rectosigmoid should lie nicely along the back, you can see these nodularities that are so characteristic. And then, of course, these patients usually have a lot of pain, and you can actually discover the pain that they have as you probe very gently in that area, and they will react when you actually come to the area of endometriosis, because they will tell you that that's where it hurts. Now, some of you may be wondering whether or not we could be missing colon cancer in looking at these lesions. I just want to show you that colon cancer is very different from bowel endometriosis. This is a case of bowel endometriosis. You can see that it doesn't occlude or doesn't really impinge on the lumen. It's more diffuse here in the bowel wall, whereas the colon cancer has a lot of color, first of all. It's also very heterogeneous and irregular looking. You can see it doesn't have the smooth walls that we sometimes see in endometriosis, and it grows into the lumen, and you can see how the lumen can become impacted here and actually narrowed significantly. Now, until recently, MRI was really the gold standard for endometriosis, but if you compare ultrasound, the way that we've been showing it, with MRI, you can see that the sensitivity and specificity for transvaginal ultrasound is really, really good, and almost better, certainly no worse than MRI. If you compare the sensitivity 98% to 83% for the rectosigmoid endometriosis. So really, ultrasound is the go-to method for evaluating patients suspected of having deep infiltrating endometriosis. Well, the deep implants of endometriosis, even though they can be small, tend to be the areas where endometriosis can be the most tender and the most painful. And it is well known that if you use the tendinous-guided type of ultrasound, and the beauty about ultrasound is that you are holding the probe and you can actually examine and detect where the patient is the most tender as you are looking at the pelvis, so that as the patient tells you, yes, this is where it's most tender, or no, this is not as tender, um, you can identify even better the areas of endometriosis. And so the tenderness-guided ultrasound is really very accurate, and it's something that MRI can't do because you can't examine transvaginally with an MRI machine, at least at this time. Let's talk about the adnexa. We have outside of the ovary, of course, we have hydrosalpinx, adhesions, tubo-ovarian abscess, and we are not going to talk about ectopic pregnancy since that is being covered by a different lecture. So is this an ovarian cyst? This looks like a complex septate ovarian cyst. But in fact, you don't know because you're given a single slice and you have no idea if you were taking a volume of this, how these septations would be aligned. So if you do take a volume of it and you take everything that is inside that volume that is cystic and make it opaque, make a cast of everything that is fluid inside the volume, you will make a cast, in this case, of a hydrosalpinx. So the hydrosalpinx here goes in and out of plane. And there is no single plane where you can actually display it as a hydrosalpinx. So by using 3D, you can actually show the entire convolutions of the tube without worrying what plane it's in. So here's another example. This one is much more obviously a hydrosalpinx in 2D, but you can see how the technology has evolved in allowing us to actually visualize the entire tube no matter what orientation or plane it comes in and out of. Here are two others. The one on top is harder to diagnose, the hydrosalpinx on 2D, and the one on the bottom, you can suspect it on this one 2D picture, but it is so much easier to use your 3D capabilities to prove that you're dealing with a hydrosalpinx. Now here's a patient who also came in with pain, and you can see that the pelvis is filled with fluid, and the fluid is insinuating itself in the nooks and crannies of the pelvis. Doesn't seem to have a capsule, really. Does have some fine septations, but these look like adhesions. They look like very fine adhesions. Now you might wonder what this is here. This looks like a solid area. So let's move our probe down and see what this is, and you can see that it's an ovary. And this ovary is trapped in a peritoneal inclusion cyst, and that is often the case, that adhesions will trap an ovary and fluid collections, loculated fluid, will appear in between the adhesions and give the impression of a cyst. But this is really a peritoneal inclusion cyst or a set of adhesions with loculated fluid. Now here's a very ugly dilated tube. You can see it's thickened. There's a little bit of fluid around the tube. There's fluid here around the outside of the tube. Here's a cross-section of the tube. There's color, abundant color. Now I'll give you a hint. This patient is very sick, has a high fever, a high white count. This is a tubo-ovarian abscess. Now, if I told you that this patient was not sick at all, but she was pregnant, you might consider an ectopic pregnancy. So it's very important to know the clinical setting that you're dealing with so that you can make the correct diagnosis. Here's a patient that came in, a young patient who had focal pain. And the tenderness-guided ultrasound led me to this rather dilated, swollen tube. And that's where her pain was. And this turned out to be salpingitis. Now, here is a patient who did have a positive pregnancy test. And you can see her tube looks quite similar to the one that was PID. But in this case, she has a positive pregnancy test. So this is presumably a hematosalpinx, and there's some echogenic fluid, which is blood. This patient has bled quite a bit. In fact, this layering of the solid material behind the uterus is clot. The clot has filled the cul-de-sac here. So this is a ruptured ectopic pregnancy. So just to finish up, there are non-GYN causes of pelvic pain. Remember, other things live in the pelvis other than the uterus, ovaries, and tubes. And we have to consider some of these other diagnoses: ureteral stones, cystitis, irritable bowel syndrome, diverticulitis, inflammatory bowel disease, adhesions, and so forth. Let's look at a few examples of some of these. This is a kidney with a dilated collecting system, hydronephrosis, in a patient who had flank pain. And rather than get a CT scan, you can see the stone very nicely transvaginally. Here's the lower aspect of the ureter, and there's the bladder, and right at the uretero-bladder junction is a stone with shadowing. And you can sometimes see, well, actually, if you were to see this in real time, you would be able to see the peristalsis of the ureter directly above that. The ureter is trying to pass this stone. Here is another loop of bowel similar to the ones we've seen, but actually not that similar, because the thickened wall here, which is on one side, is not nodular. It's rather smooth, and it continues on the length of that whole bowel loop, and this turns out to be Crohn's disease. Now here's somebody who was having pelvic pain, but you have to realize that sometimes the pelvic pain is superficial. It's not always deep, and this patient had had a cesarean section, was having pain, and this was a hernia, and you can see the bowel is coming through the little hole in the anterior abdominal wall in this hernia. So keep in mind that you really have to look at everywhere when the patient has pain, not just deep using your transvaginal approach. Here's appendicitis. Always consider the appendix, particularly if you're dealing with a right lower quadrant pain, because sometimes these will be mistaken for a tube, but they are appendix, and you can see in this case, you can see the tip of the appendix all the way out to the tip. It has an appendicolith right here with a shadowing. But the key here is the echogenicity of the fat right here. Very, very echogenic, and you can see that is different from what we usually see in ovarian and uterine lesions. This is the fat surrounding bowel, which when it becomes inflamed has that very echogenic sort of cotton candy appearance to it. Now here's diverticulitis. You see this one you can see a diverticulum quite well using 3D, but most of the time what you see, if you're going to see diverticulitis, is actually an area where there's some air here in the diverticulum, and you can see that there is a lesion here, an abscess in the colon wall. Now here is a different case, which was a very severe abscess, a huge abscess. It went on and on and on, and you can see the air inside the abscess and so forth. This was a very sick patient with a huge abscess in the pelvis due to diverticulitis. So in conclusion, pelvic pain is common, and it impairs the quality of life. It is really important to find the lesions that are causing this. An accurate diagnosis requires a combination of ultrasound, physical exam, and history all at the same time. And that's why ultrasound is so great at dealing with pelvic pain, because you can do imaging and physical exam and history all at the same time. Patients with pelvic pain deserve more than just a series of standard pictures. That is our protocol of the uterus and ovaries. Take it a step further. Find out where the patient is in pain and image it. Those that we help are among the most grateful of our patients. Thank you very much for your attention. Here are just a few references that deal with the material that we just went over, and I thank you very much for listening.